I'm happy that you all were able to join us tonight, and we tried to put together a little bit of a program for you. Most importantly, the stars of the night are our current residents, and they're going to tell you what's really going on in this department. And so, what I thought I would do is just give you a brief slide or two, and then Dr. Judith Liu, who's our program director, she'll give you a little bit of an overview as well, and then most importantly, we'll get you to our residents who can give you, a real overview, and also give you a chance to ask some questions and get some of your questions answered. So, and hopefully we'll be able to keep all that on time. So I'm actually going to just show one slide, which I like to show. I think it's an important one. Can everybody see that?
Yeah.
Yeah, I hope so. Yeah. So what I'm often asked when people come and interview is they always ask what makes a great residency program, and I think that as you all are looking to your futures, as you start to look at the various programs around the country, it's really important to keep all of these things in mind. We tend to focus on one or two things, but really I think all of it is super important. And as you start to mull over your decisions, these are the things that you want to capture. So you might even want to take a screenshot of it, because I think that this is super important. Number one, obviously, is a clinical opportunity, and what that really means is a lot of cases, a lot of patients, a lot of diseases, in a variety of different people. And so you need to see a balance of breadth and depth of the clinical opportunity, plenty of case numbers, and a graduated responsibility. So it's not just enough to have those there, but only the chief residents do them. And so you sort of want to be put to the test early on. It also has to be done in the setting of a really solid hospital system. And you can see the picture there on the right is our hospital system called Barnes Jewish Hospital. It's actually Barnes Jewish Hospital is down here on the south end and also on the north end of this campus. This used to be Jewish. This was the main Barnes. And then St. Louis Children's Hospital is in here as well. The VA is down this direction. And then we also have a variety of other clinical sites. But for the most part, the residents are spending a large part of their training here on this main campus. And you can see the main campus is adjacent to the Forest Park, which is a beautiful giant park, actually one of the biggest parks in the United States related to a city. So the hospital system is a great hospital system, and it's a good place to work. I'll let the residents tell you more about that. What we're super proud of in the department is our culture. And again, that's something that you're going to have to get a sense for in talking to people. But as you look to it, try and have a sense of the culture of the department. That's important in anywhere that you're considering. You want a legacy, and you want people that are connected. You'd like faculty members that can help you find either fellowships or jobs in the future, or connect you, in different research projects and whatnot. And so I put legacy there, but it's also it's legacy and mentorship and sponsorship. And so those are super important things to try and sort out. We believe strongly that research is a critical aspect of our training, whether you use it or whether it's just to understand how research is done. And so we're super proud of that. And Dr. Liu will talk to you. I don't think Dr. Piccirillo is with us tonight, but Dr. Liu will talk with you a bit about the research exposure. St. Louis is a great place to live, but it's important for you to think about the place you live, because when you do get out of the hospital, you want to make sure you have fun things to do. We have a great restaurant scene and a variety of other things, and then a great place for a spouse or significant other to find a job. And so those are the things that I encourage you to try and sort out in all of this. Those are, a sort of a brief list, but that really encompasses an awful lot. And so I would be the first to tell you that I think we have all of these things in a big way, but I'll let you learn that for yourself. So thanks for being here, and I'll turn the reins over to Dr. Liu. Thank you.
All right, let me just bring this up here. Okay, can you see my slides now?
Yes.
Okay, great. So, oh, I got it going. Whoops. Okay, so the our program is actually a consortium that consists not only of Washington University, but the Barnes Jewish Hospitals and the St. Louis Children's Hospital. as well as the VA John Cochrane system. Despite the fact that it's these main three hospitals, there's a bunch of other satellite sites that the residents go to. We have 5 residents per year. 3 of the residents match into a clinical position, which is 5 years, and then 2 match into a current T32 system, which is 5 clinical years plus 2 research years. And I'll talk a little bit more about that program and how it's transitioning in just a minute. And again, the main training locations are the ones that we mentioned already. And we have a variety of satellite sites where our faculty go to see patients and do operative cases. And so our residents go there too. But you're still attached to the main hospitals and you're anchored there, and you go there again following where the clinical cases and the office hours are. Okay, so where do our residents come from? Here is just the map of the US with where everyone comes from. So you can see that they come from the West Coast, Washington and California, as well as a good strong smattering in the Midwest, Texas in the South, as well as over to all the way to the East Coast to New York and New Jersey. So they come from everywhere. Where did residents go to medical school? They've, again, mostly in the Midwest and the East. And we have one resident who went to Costa Rica. Actually, we have now one who is from Venezuela as well. Somehow I missed getting him on my map. But this is where they mostly come from. So some distinctive aspects of the WashU residency. We have a long history of leading in head and neck cancer surgery. Dr. Joseph Aguirre was a chairman back in the 1950s, and he was one of the leading surgeons who basically took over head and neck cancer surgery from the general surgeons, made it otolaryngology. We are a level 1 trauma center for both adults and children, so you will be well trained in trauma, and I'm sure the residents can tell you more about that. Because we are a large urban center, but with a large rural areas around, we have a 200-mile referral radius. So it is very common for me, for instance, to see patients who come 3 or 4 hours in order to come to see us. Also, we're located at Washington University Medical Center, which, even though we are, we have a great residency in itself, the Washington University Medical Center has great residency programs in just about all of the different residency programs. So you are training alongside residents and great medical students who come from all over and who are really smart, hardworking people who have great innovative ideas, and you're working alongside them. So it's a wonderful opportunity to have these colleagues across different specialties. We have excellence in clinical and research training, as Dr. Buckman alluded to. We have excellent success in obtaining fellowships. Around 80% of our current trainees currently go into fellowships afterward, but it's varied from time to time. And we have quite a bit of training and mentorship for academic practice, as Dr. Buckman again alluded to. So here is the website for more information. Hopefully you've already made it to our residency website. And then I have listed here a little bit more information about our program specifically. There are prior Taste of WashU otolaryngology videos from 2020 and 21 that you can have access to. Remember, we do all of our applications through EROS. Hopefully you are aware of the preference signaling program that otolaryngology has. You can put in your signals between September 1st and September 21st. So that's just next week. So please, if you have questions about where you should preference signal, feel free to ask us and just get them in so that we and other programs can know that you're interested in us. The deadline for our applications, when we as a program will be downloading kind of as a final, all of the applications with the letters of recommendation will be October 7th. So that we can do a preview of all of the applications. And then we will adhere to the common interview offer day that hopefully you have heard about from other programs, which will be on November 10th. So that's a Thursday. You will get the interview offers. You have the weekend to think about it. And then on Monday, the 14th, you send in your acceptances. And we will work with that, those deadlines. So that's all for me. This is some slides that Dr. Piccirillo, who is in charge of our physician scientist training program, has sent. And so this is just a brief overview from him. The physician scientist training program is a 7-year research track that I had mentioned earlier. Because the program is housed and paid for through the NIDCD, which is the National Institute on Deafness and Communication Disorders. The research should be in the areas related to hearing, balance, taste, smell, voice, speech, and language. Beginning next academic year, though, July 2023, when you would be entering our program, our current NIH grant funding will be transitioning from a T32 to an R25. So the change in grant funding provides research residents with a unique 2-year research training experience comprised of 80% protected research time and 20% clinical activity. So that's a little bit different than what our current T32 residents are having right now, which is 100% protected research time, and they don't engage in any clinical activity unless it's moonlighting. And your immersion in clinical activities will be an excellent way to reinforce the complementary nature of clinical practice for informing research. So the research team is comprised of not only Dr. Piccirillo, but Dorina Caligari, who is an assistant professor and a research statistician. Many of our residents work with her to help with statistics, calculate sample size, and help with the interpretation of those statistics. Sarah Kukeljohn is a manager in the Division of Clinical Research. She is a nurse who has had tons of training with clinical research, so she is able to help with IRBs, animal studies, and make sure that when you put in a protocol that it's going to pass and not get hung up on a whole bunch of bureaucratic or administrative details. So she's an invaluable resource. And if you have any questions, please feel free to email Dr. Piccirillo and visit the website for the Physician Scientist Training Program. And hopefully we get a chance to see you at another time. And that's all for me. I'm going to hand it over to our resident co-hosts, Catherine Chang and David Lee, and we have a bunch of residents from a variety of clinical and research years. So please make sure you make the most of their expertise and their knowledge of the program to get to know us.
Thanks, Dr. Buckman. Thanks, Dr. Liu. Hello, everyone. I'm David Lee. I'm a second-year T32 resident. As Dr. Liu was just saying, 2 years clinical, 2 years research, 3 years clinical. So entered my research finishing PGY2, but will probably slide back in as a PGY1 or something like that. And this is Catherine.
Hi, I'm Catherine Chang. I'm one of the PGY4 residents. David was actually in my initial class, and I leapfrogged him because I'm in the clinical track. So when I'm a chief, he will be a 3, and that will be a really great relationship.
Very nice. Yeah, so this is just an overview of kind of what we think about WashU, why we enjoy it, and as honest kind of communication from us to you. This is very casual, so please feel free to either unmute and ask a question or throw it in the chat, and one of us will field it. But with that, we wanted to start with something foundational, which is just the resident rotations here. And I know we had just talked about it, but maybe from a resident's view, we can kind of give what it looks like from our perspective. Oh, I forgot, just gotta kind of inject random bits and pieces. This is the Winter Festival at Anheuser-Busch?
It was the Christmas lights.
Christmas lights, Botanical Gardens?
No, it was at Anheuser-Busch.
Okay, then yes, very good. Every year around the holidays, things get festive. This is rotations by department, and so we have all of the different subspecialties. I wanted to talk about team by year and as well as the number of attendings. Dr. Buckman mentioned breadth and depth. And again, just to reiterate my perspective on that, breadth is the number of attendings that you have per department to learn all the various ways that they were trained. You can kind of choose what is right for you. Of course, when you're in the operating room, you choose what the attending enjoys to do. And so in head and neck, we have 6. In general, we have 3, and that includes a very broad general. We do silent endoscopy. One of our previous chiefs of last year is coming on as a sleep surgeon, and so it is a really quite a nice breadth of good old-fashioned general otolaryngology. Next is laryngology, facial plastics, reconstructive surgery, rhinology. On the ped side, one of the nice things is that the St. Louis Children's Hospital is in the same kind of complex as the rest of our training. And that makes it convenient. There's also a bunch of folks out there, and it's a great learning experience. And then another strength of ours is otology and neurotology, of which we have 5 attendings of various training. One thing to note by the team by year is that you get early exposure to all of these different departments. You rotate through each of them as a 2 in some capacity, usually in 5 to 10 week rotations or something like that. And it's nice because you get broad exposure. So if you really don't know what you want to do, because ENT is one of those fields where you can see yourself being happy doing a lot of different things, it's nice to get at least a flavor, more than just being a sub-I or more than just research, but actually being primary surgeon for a lot of things and assisting in others and just kind of getting involved in the milieu.
Yeah, and I think one of the nice things about our residency, which I'm sure other residencies do this as well, but you do have a lot of graduated responsibility, but we do try to get our juniors into the operating room very early on during their training. It's not the case at all that as an intern or a PGY2 that you're just doing floor work or just taking call and rarely seeing an OR. That's not the case. And so, especially as a PGY2, I felt like that was a huge growth year, surgically, and I was doing a lot as a PGY2 that I was very surprised about. And so we're certainly a department that emphasizes, early time in the operating room, harnessing those skills very early on in your training. And I think some of the interns probably on this call can speak to the OR opportunities that they've had, because they're in the OR a lot actually as well, on their head and neck rotations and occasionally on peds, and certainly when they're on consults, their consult rotation. But can't emphasize enough, how strong the training is here. And I think that's really important as you're doing your interviews to kind of learn about sort of the weaknesses and the strengths of each program. There's not a ton of weaknesses that really come to mind. I feel like we do sort of have everything that you would want in a training program. So there's not any major deficits that at least come to my mind.
Yeah, and just to highlight usual strengths that at least I think we have, and a lot of residents will agree, is again case volume in head and neck. It's where you learn a lot of soft tissue work and get efficient on your consults when you have a big lack in the ED you have to take care of. And also the otology, neurotology case volume is very healthy there as well. Some cases that I did as a 2 that I was not expecting to do on head and neck was, even though we had a fellow and a chief and pretty much every single year on our team, as a 2, I was still in a prodded by myself, finding facial nerve as the primary surgeon. And then on the otology, neurotology side, I'm through almost all of my cases I need for a cortical mastoidectomy, and it's fun to have the drill in the hand, and I'm sure the attendings are sweating a little bit, but it's fun. It's really good.
Nice.
This is
actually one of our attendings. He really likes to bike. He's a head and neck, one of our head and neck attendings, and he occasionally will come to weekend rounds right after his bike rides. So we thought we'd like to include that in our PowerPoint.
Just slightly uncomfortably sweaty. Next is the VA. One of our previous graduates, Paul Zolkind, he's a head and neck surgeon, did his training, fellowship rather, at Stanford, and is now back chief in the VA. It's a PGY5 and a PGY3 rotation, and it's really the PGY3 service, or so I'm told. But it's you run your own clinic, you have your own patients that the residents see, you book your own cases, and it is a great place for not only general otolaryngology, but particularly head and neck with Paul Zokine there, but also we have a neurotologist, WashU, who does cases out there, as well as the facial plastics experience. As someone that's done the VA rotation,
Oh, yeah,
any thoughts on it?
It's very necessary. I think that it's a huge strength of any program. If you're looking at programs, if they have a VA, I think that automatically makes them, that's automatically a bonus. Just because it's really like your clinic, your service, and that's sort of a unique part of the VA, kind of like when residency programs have like a resident clinic, for instance. It's your opportunity to really like be the attending in a lot of circumstances. And so I think that's a huge plus of our program, that we get to work at a VA, and it's actually quite busy. Like, it's not slow at all. It's quite a busy rotation. You get to operate a lot, and obviously see a lot of clinic patients as well. But it's definitely a great rotation, I think, that we offer.
Right, and it's huge growth as a 3 on call. It's you and the attending. There is no one else, and so you just learn to make a lot of decisions with confidence. Oh, this is the rest of my PGY class I originally came in with, from left to right.
You were post-call. I think that's why you weren't there.
I'm sure I didn't get the text. That's Sam, Ashling, Teresa, who's on the Zoom, and then the lovely co-host herself at the Arch. This looks like 4th of July, possibly.
Yeah, it was 4th of July.
Yeah, very
My
cool.
first 4th of July in St. Louis.
Nice. They do free concert out there every 4th. It's a nice time. Consults, something I do know a little bit about. I guess we'll talk about call here as well. Consults is just like any other institution. Whatever comes through the door that requires an otolaryngologist, we get called. The team itself is a PGY1 and a PGY5, and then during the day, it's a mixed bag of either a PGY2 or a PGY3 covering day call. For our intents and purposes, day call runs from 6:30
to 5:30.
To 5:30. We have a pager, and you just hand it off to the next person coming on night float. Before we get to there, what I liked as an intern on consults is not only just kind of understanding more inpatient medicine, and also how to communicate with other healthcare professionals. And you're a specialist, even as an intern, you're a specialist, and understanding how to get at the question that they're asking, even if it's not being asked in the way you're used to hearing it, is just great to understand as a one. I did a lot of trachs. I think that's universal as an intern, and you're the primary surgeon with the 4 or the 5, and the attending usually doesn't scrub in, and it's great as it's a 5 to teach and as a 1 to do. You want to talk about OMFS Wednesdays?
Yeah, to be honest, I remember as an intern so we have an OMFS group here. They don't have residents. They're very autonomous, like they don't need us to cover their cases, but we're certainly welcome to join their cases if we want. And it's actually, they do some cool things. And as an intern, I remember scrubbing like mandibles, where I was like the only resident helping the attending, suturing, doing alveoloplasties and things like that. And so it's actually, it's honestly a great resource, I think. I think these days our consult service has sort of blown up. And so on Wednesdays, I think the consult team oftentimes has their own cases. But the interns do rotate with OMFS now as interns, and are able to get that experience sort of more formally. But yeah, it's a busy time. And so I think somebody asked in the group, how is the consult system designed at your program, and what's your call schedule like for juniors? Do we have a slide about night float?
We do.
Okay.
Yeah.
So part 2 of this question will be explained in a later slide. But as David said, you take primary call as a PGY2 and as a PGY3. we have a night float system, which for those of you who don't know what that is, meaning a resident is on call at night for the entire hospital and in charge of all the inpatients. It's either a 2 or a 3. And then during the day, it's a 2 and a 3 as well. And then the weekends are covered by the 2s. And so when you break it down in terms of 24-hour call, as a PGY2, the only 24-hour call that exists, really in-house call that exists, is on a Saturday. So there's only one 24-hour call that needs to be covered every week, and it's by a PGY2. And so it ends up being pretty nice, because I feel like 24-hour call is like brutal on your body. And other call systems, they do it Q3, Q4, which I personally think would be really, really tough. And so I definitely think from a quality of life standpoint, like having a night float system is really good. Oh, are you wearing the same exact shirt as you?
Unintentional. This was after our in-service exam, conveniently right before COVID, and it just, we got all the people together that happened to be wearing the same color palette, and we won in Flip Cup as well.
That's funny. I can't believe you're wearing the same shirt.
I've only got 2 pieces of clothing. So to reiterate what Catherine was saying about night float, a 2 or a 3 for 5 or 6 weeks at a time will work nights in the hospital. Their shift is usually 6:30 to 5:30 or 6:30 p.m. to 6:30 a.m., something like that. And it's painful for sure. You handle every service that exists at Barnes-Jewish Hospital and St. Louis Children's Hospital, as well as any new consult that comes in overnight. So you learn to be very efficient, and you get much better very quickly. And anytime you're not on night float, you do not have to take call overnight. And I can't speak highly enough about what that does for your, sleep-wake cycle and all things that make quality of life actually really nice. A lot of programs do and should have wellness programs, but another way to think about wellness is, do you get out consistently on time to go live your life and do other things? It's important to think about. Some call schedules will allow that, some won't. My experience so far is that, if nothing random and one-off comes in, you're consistently getting out, especially as you progress in your training.
Yeah. Oh, great.
Just another photo of otolaryngology, bros being bros.
Let's call on some people, because there's other people on this chat that I feel like we've done enough talking. All right, so we want to talk about our T32 program from a T32's perspective. I know there are T32s on this call. Who should we call on? Ben Wally, are you on?
Hey, yes, I'm on. How are you?
Video.
T32. So it's an opportunity for you to take 2 years and dedicate them to research. And I think we have a very good environment here at WashU. That's why I did T32. I'm a PGY4 now. I worked in Dr. Zavaios' lab. Dr. Zavaios recently moved on and became the chairman at Pittsburgh. And so I was in his lab for 2 years, and it was really awesome. We did head and neck cancer genomics. But there's a lot you can do here at WashU. A lot of people do more clinical type of research. Some people get an additional degree during that time. And I didn't get that degree, so I may let David or Teresa comment on that degree. But I really can't say enough about the research environment at WashU. It's very collaborative. There's always somebody on this campus doing something that may dovetail with your research. And I mean, I have one example. I was at a random seminar in the middle of my first year of research, and I went up to the guy at after the talk, and we basically became collaborators, and we got funding together. And it's just, all it takes is just like a hello and a common interest here at WashU, and you can become collaborators and do some good work together. So So I don't know if you guys want to talk a little bit more about the MSCI. I did more of kind of a like tumor genomics stuff and didn't do the MSCI, but I think no matter what you want to do, if you want to do more basic translational stuff or if you want to do clinical research, we can support you here. So
I can chime in about the MSCI. So I'm Teresa Therakan. I'm like David in my second year of the T32 program, and I am doing purely clinical research in Dr. Piccirillo's clinical outcomes lab. So I'm working on an IRB for a trial right now, and I have another prospective study going on taste and head and neck cancer. That's a really great opportunity. Dr. Piccirillo is the program director for the T32 years, and it's great to pick his brain because he has many, many years of experience in clinical research. And a lot of people end up working with him during their T32 years, but also for the clinical residents, you'll work with him when you have your research elective on your PGY 3-year. For the master's program, it's a Master's of Science in Clinical Investigation, and T32s are welcome to enroll in that, and the department pays our tuition. I have really enjoyed taking statistics classes and research design classes. A lot of those have influenced how I've designed my projects. And there's also an encouragement of entrepreneurship, that we have a strong relationship with the WashU undergrad and other graduate schools. So I'm now working on a grant application for seed funding for an app. Another thing is the relationship with the Cortex, which has a focus on biotechnology, and that's another place where people build collaborative relationships.
Yeah, and I think included on the slide is just some humble brag, I think, points for research at WashU. But we're always I think in like the top 6, top 4 for NIH funding. So we're a very well-funded department. And so as I think Ben and Teresa explained, especially if you're a T32 and you're interested in a more intense, I guess, research experience and basic science potentially, that's really huge. You can do some really great work, but that's even open to clinical residents. We also have a lot of residents that are funded by the AAO core grants, which are very prestigious, David being one of them. I know like 4 or 5 that I've worked with off the top of my head that have received core grants. Our residents do really, really well here. And so hopefully we answered, someone submitted, I think, a question about, clinical and T32 research for basically T32 and clinical residents, and hopefully we answered those questions.
And it looks like there's a question in the chat. If you're interested in getting another degree like an MPH or MBA, are there options to take time to pursue those without specifically being in the T32? In the last several years, no one has sought that out. So I don't know if Dr. Liu is still on the call and could comment on that. But if not, that'll be an individual discussion with her, probably, because we haven't had anyone take a year off for anything other than the T32 in a while, I think.
Yeah, so we haven't had residents seek out an MPH within the residency, just because our residents tend to be pretty busy, and I think they can attest to that. An MPH does take quite a bit of time, but I think those who do the MSCI find that a lot of the coursework is very similar to the MPH. The MPH has different foci, and so there's always more opportunities for education after you've done your residency training.
I'll add that I'm taking some of my MSCI classes are in the public health school, so you can always take electives there if you want some of that.
I didn't realize the Colin Chen picture.
There is an executive MBA program at WashU that meets on the weekends. I think that it'd be hard to do as a clinical only resident, just because of call and weekend duties and stuff. And you basically have to go every Saturday, and I think half your Sunday, like for every weekend for like a year or two. But it would possibly be something a T32 resident could get done. I looked into it briefly, but found there was not going to be any support for tuition for that, so I didn't go any further.
I came to a similar impasse. This is a holiday party. Yeah, just.
I think it's our the White Elephant Party. Did we have one last year? I feel like COVID has botched a lot of our traditions, but we might have had like a secret one where we didn't actually gather. Okay, I think so. Dr. Buckman actually had a great slide that showed sort of where do we work, and as he sort of alluded to, outside of the mothership, which is Barnes Jewish Hospital and that complex with children's, Barnes has been like expanding like crazy, even just while I've been here. They built new surgery center sites. So surgery center is basically a building that just cranks out outpatient surgery, maximum efficiency, minimal turnover times. So you get a high volume of cases and you get home on time, which is great. It's sort of a private practice model. And we've also acquired some of the community hospitals as well. And so are these all the little places?
Yeah. So this is us. This is Central West End. This is the VA. Up here is Christian Northeast, one of those community hospitals we were discussing. This is Barnes West County, where you do a lot of
outpatient laryngology, facial plastics, rhinology.
And then this is
the ASC.
ASC, yeah, that's the surgery center we were just talking about. But in terms of where residents live, I have lived in the Central West End, and now I live in the Grove in this area. People live in Tower Grove over here as well. We have one resident that lives in Clayton, and then a lot of attendings live in Clayton. In terms of a drive here to here without traffic, which is standard, is about 25 minutes, 20 minutes. And that's about the same distance from here to here. So one of the nice things is that you really don't spend a lot of time in transit in residency. I did my med school in San Francisco, and just getting from site to site was very difficult for me. And so this is a wildly different, and like not having to pay for parking most times is street parking is kind of a neat concept to me. But this is where we work. And then more of the kind of what we do and just getting a sense of where we are and where residents live relative to other things. This is downtown. In the yellow is like restaurants that I personally love. And this is
David Lee's hobbies and interests.
Yeah, just kind of threw it on there. This is Anheuser-Busch Stadium down here. This is a Tower Grove park. Their farmers market every Saturday is fantastic and wonderful. There is just kind of a bunch of random stuff to do, and it's a really fun city to live in.
Yeah, it really is. And not that it should be surprising, but I feel like people are generally surprised when they come to St. Louis, how like diverse in terms of like activities or interests. There's actually a big like sort of art community here. I mean, I think your girlfriend is sort of more involved. Your fiance, I should say. I'm so sorry. So sorry.
Oof, I'm still working on that myself.
But more into that sort of scene, but like lots of good shows, like good theater here, and it's very accessible. And so I feel like a lot of like art shows or good theater, for instance, in some bigger cities, you have to pay a lot of money for, or there's long sort of waits. You have to make reservations far out in advance. Whereas in St. Louis, like a lot of that stuff is very high quality, but it's very accessible to, you can decide like 2 days before that you want to go to a play, and you can just do it. And we have free sort of theater like Shakespeare in the Park and things like that happen in Forest Park and just open to the general public. And then outside of that, we have a really good sort of sports culture here as well, downtown especially, with our professional baseball and hockey teams. And lots of outdoor things to do. You know, we mentioned Forest Park. It's bigger than Central Park. It's a huge park, and within Forest Park, you know, there's our zoo, there's the planetarium, there's 2 museums, like there's a bunch of biking trails.
There's 2 golf courses.
There's 2 golf courses. There's a lagoon where you can rent out paddle boats. Like, it's a really cool place to be, and it's literally right next to our hospital. Like, some of our residents use Forest Park to ride their bikes to work. Like, it's literally right across from the hospital. And many of us live by Forest Park. And I mean, I take Rupert there, my dog, like once a week for a nice little stroll. But my point being is that there's a lot to do in this city. It's a very affordable place to live, and the fun things to do are also very affordable. And so I think that makes for a really great sort of interesting quality of life, you know, as a resident. You know, you don't have a ton of money.
It's true. All the above.
Yeah. Anyone else on the call want to chime in? I saw, you know, the other Catherine was on the call.
Oh, thanks, Teresa.
Hi, I'm the other Catherine. I'm one of the interns. Yeah, I just kind of echo what they have already said, but I grew up in Chicago. I went to med school in New York City. And I've been pleasantly surprised that there's lots of stuff to do in St. Louis, and like different strokes for different folks. So like I go to the farmer's market, it's really nice. Like my little cohort of friends that I have here, my co-interns, there's really nice restaurants all over, and like everything is affordable. So in contrast to like New York City, you can really afford to go to like a nice restaurant and have a good dinner with your friends after like a long week at work. So it's been really fun so far.
Oh, just a medley of random things. This was one of our resident socials at a wine bar. I don't think we've talked about the resident socials yet.
Was that
but,
Sasha's?
I think so.
That is Sasha's.
Yeah,
I recognize.
Yeah.
There's
All the
this,
wine on them.
There's this great place called Sasha's where they have this like happy hour basically from like after 9 o'clock, where any open bottle they have, you can get it half off. You can get a glass half off. And these are not like baby pours. They like basically fill your entire wine glass with wine. And you know, it's literally like $5 a glass. So love that place. I don't think I went to that one, but
No, I think you're on call.
But I go there like frequently.
And then
this is at Academy.
This is a fresh one, bottom left. We were just at Academy. It was a fun time. Bottom right, Raj, previous resident here, now attending at the VA. It's kind of like a big baby holding a baby that's not his baby. And then top right is at Dr. Buckman's house for one of the I think a holiday party based on the attire. Very fun. It's nice to kind of get out of the hospital and see people kind of more in a casual setting. So it's all good stuff.
Okay, I'll interject because I want to show off my baby, because I also want to say this is a baby. She is 3 weeks old, but anyways, just one, she's getting a little probably tired of the meeting, so I'll say that very great family place. Not everybody is married or has kids, but a really good mix, I think, of people that are actually have that. But it's also like very supportive environment for that. St. Louis is an awesome place to have a family, and just in general to be able to do. It's just very really cool city for that. So that was my last little plug, and I may head out, but reach out if you have any questions.
Yeah, he's a new father now. But yeah, we do actually, I guess I can't really speak to having a child during residency because I didn't, but we do have quite a few residents that have had children or had children coming into residency. And in general, I feel like our program is very supportive of that. You know, you get, I don't actually know how much, maybe Dr. Luke can speak to how much maternity leave you get if you're, you know, a female resident and you have a child during residency. Barnes Jewish Hospital does give you maternity leave. WashU also has like a daycare that a lot of our attendings use, but I know that some of our residents have used as well. So you drop your kid off and go to work. And so in general, it's very much possible. And having kids in an affordable city is also a lot easier, I would think.
healthcare is good as well. So again, wellness programs important, but then just hit the fundamentals, good healthcare, good pay, getting out on time.
Yeah.
And, that takes care of itself a lot of times. These are some things we do. Chairman rounds, Dr. Buckman holds rounds once every other month or so with just the residents. And it's a quasi leadership course, which is really nice to get his perspective and perspectives from some of the other residents. We sometimes do a book club with it, or just air out any grievances that we have brewing. It's a nice dialogue to have, the ear of your chairman, and respectfully so.
And he makes us move the tables so that we sit like we're at a big dinner table.
Nice at the round table.
Like a 25-person family dinner.
So it's good stuff. And yeah.
We also have monthly resident socials. So back to sort of, resident wellness. Sometimes in a big department, which we have a big department, we have a big residency too, since we're 5 a year. And we're kind of spread around different sites. We try to make it a point to like get together and do something every month. And so the department actually gives us funding. They give us $500 a month. Our esteemed social chairs like David and Teresa plan, events, whether it's going to Bar K, which is this bar that you can bring your dog to, or like a canoe trip that you guys went, a float trip you guys went on. So it's a different activity every month. It's sponsored by the department. I think that's really cool that our department actually goes out of their way to support stuff like that. And then we had some pictures of the White Elephant holiday party. We have a golfing tournament. Dr. Buckman always has a couple of events at his house. He'll have like a summer barbecue to welcome like the new residents. He has his Christmas party. But in general, I think as a department, we try to get together, be social, and be more than just sort of work colleagues. And I can speak, that I feel like I'm very good friends with all of the residents. You have your own kind of little group, but all of us are good friends and feel like we can count on each other. And I feel you probably feel the same way, yeah.
Feeling's mutual. Can't check. The feeling is mutual.
Okay. Submitted questions.
We're getting on the tail end here. Let me push this away.
Who hasn't talked yet? Who's on is Dan Romano is on. Have you talked yet, Dan Romano? Okay, we'll call on him at some point.
Yeah, I'm sure he's been active on the chat. He seems like a IT specialist over there, just picking things off. Autonomy. Let's talk autonomy again in the OR throughout the years. What has this experience been like every year in the residency? Something I'm sure I butchered that question as I was writing it.
Dan, you can answer this. You're a PGY2, and so you've done intern year, and now you're 10 weeks or so into PGY2 year.
Yeah. Hey guys, I'm Dan. I'm one of the new second years. Yeah, something I wanted. It's a little bit related, maybe a little bit off topic, but I feel like a lot of residency programs will emphasize like how much early operative experience they have. But I sort of wanted to put some numbers to that, because I feel like it's sort of an abstract concept and we say vague things like we get a ton of early operative experience. And so I was dabbling in my case log. Well, Teresa.
Yeah. We know Dan's not getting emails about uploading his case logs like me.
Yeah, I'm very prompt. So. Yeah, so to this point, I'm like 15 months into residency. I've logged like close to 400 patient cases and over 600 like total cases. So that's a ton. And not every single one of those is as a resident surgeon. A lot of it is as assistant surgeon, so assisting more senior residents or attendings in cases and not doing sort of the primary moves. But definitely over the course of your intern year, you'll see a ton of growth in terms of your own operative ability. And I feel like one of the benefits is we've got attendings who've got sort of varying comfort levels with residents in the OR. And so you'll have attendings who will really emphasize the fundamentals and teach you everything from like how to hold your scissors and tines up, tines down, in sort of very fundamental things. And you'll have attendings who will, with a watchful eye, allow you a little bit more freedom and autonomy, and sort of balancing those two things. You'll definitely gradually see yourself get better. So I started on rhinology this week. and already did a maxillary antrostomy and an anterior ethmoidectomy as a primary surgeon. Dabbled in a little bit of sinus surgery as a 1 on the consult service, doing some acute invasive fungal, just sort of basic nasal endoscopy and trying to get into the maxillary in patients with a platelet count of like 5, with varying success.
Solid.
But you'll definitely sort of get those opportunities. I especially feel like the consult rotation is super valuable to sort of dabble in a lot of different subspecialty areas and sort of see those procedures and start to get a little bit of hands-on experience. And then as a 2, you'll rotate through pretty much every subspecialty and sort of start to get more and more reps and get more autonomy as you work with the same surgeons repetitiously. So I feel we've got a great program here, obviously.
Oh, how do we go back? I'm so sorry. I screwed this up. That's a great point. Thanks for giving those numbers. But yeah, I feel similarly. I think as a 2, like when I was on head and neck, and maybe I just had a weird experience, but I don't think so, because I think Teresa had a similar experience when she was a 2 on head and neck. But I did like a lot of, my chief was like all about me doing neck dissections. Like I think he made it a personal goal to, like, whenever he was in a neck dissection with me, that he would be supervising and I'd be doing it. And his goal was that I would meet my my minimums to graduate. So I actually did 28 neck dissections as the primary surgeon when I was on head and neck as a 2, which I'm not saying that should be the goal for everybody, but just to give you kind of a taste of like what operative experience is like here. I'm not saying that we just kind of let our 2s kind of go crazy and do inappropriate things, but you do get the opportunity to do some pretty advanced work, you know, and I think the attendings are very motivated to teach us, you know, how to do mastoids or do whatever. And so, yeah, thanks for making that point.
Yeah.
Another question. Oh, sorry. Does someone want to say something else?
Oh, sorry, Catherine. I was going to emphasize that a little bit. I feel like our seniors are so confident by the time that they're 4s and 5s. No, like appropriately confident. Like you'll get to the point. Yeah, like I feel like our program does such a good job of training really competent, really proficient surgeons, even by like the PGY4 a year, that they'll be comfortable starting to teach junior residents. And so that's something I've been on the receiving end of.
Yeah.
A lot of PGY4s who are like already, at least to my eye, and I'm sure I'm missing some of the subtleties, but operating at like a junior attending level in some of these cases. And so when you've got seniors that are operating at that high of a level, they'll obviously be comfortable sort of allowing you to be the primary surgeon and assisting in that capacity. They're not still trying to learn how to do like a neck or learn how to do like a like some of these cases that others might be at other programs.
Yeah, like good juniors make good seniors, make good juniors, and WashU is pretty deep in that cycle. So you'll
it's a vicious cycle.
Yeah. What is WashU's relationship with the surrounding community, interdisciplinary opportunities between ENT and other subspecialties and departments? We work very closely with neurosurgery in particular, both the anterior skull base as well as the lateral skull base, so rhinology and otology, neurotology.
Usually head and neck when we do crazy skull-based cases.
And same with ophthalmology,
Yeah.
both for cancer, if you have to do like an orbital exam or something like that, but also on call. You just end up, you know, you're both walking around with headlights on and end up seeing the same facial trauma patient often. So there's that. You'll rotate off service as a 1 onto plastics, and you share face call with them. So and anesthesia, of course, the airway when responding to a difficult airway, it's the I guess levels are anesthesia stat and then difficult airway. So anesthesia stat means anesthesiologist comes, intubates, and then difficult airway, anesthesiologist is already called, and we show up as well to provide either surgical airway or fiber optically through the nose. So yeah, in general, with others within our WashU, very good. And then surrounding community, as an institution, we're very integrated within the community. Within ENT, we do an annual free head and neck screening services, and we, as kind of the hospital around the area, we just see everybody and everything, and overall, I would say we have
We're the safety net
Yeah.
for the city. I mean,
a
we
good
have,
relationship.
we're the safety net for the city. We, you know, SLU also, St. Louis University across town is also a safety net in ways, but we just have so many more beds. And so I do feel like we see, just like everyone in the community, we're like at the same time, you know, not a county hospital, but we see like county hospital patients, you know. So yeah.
There is no county hospital in this city, by the way, just so everyone's clear. Like, so you get it's not like those patients are going elsewhere. They're either going to often Barnes or SLU. So just that, like our experience is kind of a hybrid. Just on this topic, our experience is kind of a hybrid between working in a, you know, like where I came from, there was a university hospital, there was a county hospital. And they were very separate things. And, you know, the patient populations were totally different. The attendings that worked there were totally different. And Barnes is you know, in my experience, kind of a hybrid between those things.
Okay, somebody asked, since interviews will be conducted over Zoom, what is the one thing you would show us that you were unable to do in the virtual format? I actually think like the city, like, right?
Yeah, and like I showed up. It was like, I've never been to St. Louis before. Had some
West
really
Coast
good,
boy, you know.
had some really good barbecue. The people were nice. Like, oh yeah, like this could totally work. It's hard to kind of explain the vibe of the city, but it's
Yeah.
just probably just going out generally when
Yeah.
we do an applicant social.
We do
That's what I miss the most.
We do an
honestly.
applicant social like the night before, and then we do like these like city tours, obviously after your interviews, and then we usually like after, because usually the interview's on a Saturday, and so for people that are staying in town, we usually are like, hey, the residents are like going to a bar afterwards, like you guys come if you want. And that was always pretty fun for the people that showed up, and they got to like let loose a little bit and just sort of be themselves since like the interview was over. And so that's probably the one thing that I would want to show you guys that we really can't do justice on Zoom.
Yeah, just like how we vibe and so on and so forth. What about WashU ENT surprised you after starting residency? That vague phrase, early operative experience, for sure. Just like in there.
Yeah, it is pretty shocking.
Totally just in there. What is something you wish you would have known or you wished you would have asked when applying?
Ooh, that's a good one. Any takers? Yeah, I mean, there are a lot of things, I guess, but it's I don't know. It's hard to know because I feel like as a medical student, I didn't know what I needed to know.
Right. I think maybe the one I would say is it's about mutual fit as much as it is about quality of applicants. So don't compare to other people throughout this process, and don't lose kind of what makes you kind of more authentic and genuine, because that's ultimately what will shine through about why you want to do this. And I remember writing in my personal statement just something very personal and just kind of just saying it out there and just letting it be that. And most interviews I had, it was brought up in more than one interview. So the people that like you, and the people that won't, you won't hear from anyways, and it wouldn't have worked out. So just kind of roll with it. Just kind of roll with it.
Because I feel like, you know, you guys will inevitably do this and make like these crazy lists and comparisons, and there's probably an app for that even. But for me, like I have like all these things, like, does it meet this criteria, this criteria, this criteria? But at the end of the day, it's also like a gut feeling type of thing. Like and maybe this is harder to get on Zoom, but like on my interviews, like there were just some programs where I was like, yeah, like this program is great. I really clicked with all the attendings. The residents are really cool. And I just see myself there. And there were some places that I was like, yeah, I don't see it, you know? Honestly, that's the way I felt about WashU. Like I walked away from the interview and I was like, I really liked everyone. I really clicked with all these different people. Like I really just see myself here. Obviously WashU did meet a lot of those kind of criteria things for me that Dr. Buckman showed you on that slide, but ultimately it was kind of a gut feeling for me. And so that's probably what I would tell people. Like, I feel like people feel really pressured to rank like the top 5 Doximity ranked programs, but like, if you had a really good feeling at a program and you just see yourself there, like that should be considerable in terms of making your rank list.
You'll do best where you see yourself thriving. And so don't discount that as what I would say. And yeah, that's pretty much what I would say again. But anyways,
Great segue.
Yeah, that's what we've got for you. Thanks for sticking it through to the end for those that are still here. And I'll get your emails from Jana and send you mine if you have any lingering questions. Happy to stay on as well. But thanks, fellow residents, Dr. Liu, Dr. Buckman, and to you applicants. Good luck.
Yeah, and Jana and Maria, Jana, I think might have sent you guys the email to organize all of this, but certainly, if you guys have any sort of questions that you want answered in an email form or a text form, she can give you our emails. We're happy to talk to you guys more about the program or just answer any other questions you guys have. But everyone's sort of bandwidth for these types of virtual presentations, I feel like 1 hour, longer than that, start losing people. So we're going to sort of wrap it up here.
Appreciate y'all.
Anyways, thanks to all the residents who stayed, but you guys should get on